I'd like to call to the stage now Dr. Alloway, who's going to speak about navigating rapid change in ovarian cancer, PARP inhibitors in clinical pathways. Dr. Alloway.
Thank you. Good morning. I'm from Pittsburgh, and these are my disclosures. So the learning objectives for this talk are the following. Analyze within-class distinction of PARP inhibitors, review recent clinical data concerning the safety and efficacy of these agents, discuss current guideline recommendations for ovarian cancer and strategies to improve the incorporation of recommendations into clinical pathways, integrate PARP inhibitors into evidence-based ovarian cancer clinical pathways based on discrete PARP factors. So my first slide is just a historical background about ovarian cancer approval and a treatment landscape. So if you look at the slide, from the beginning of the slide to approximately, there you go. From there to here covers a period of approximately 40 years. And from that point to 2018, as you can see, is only a period of about 4 years. And in those first 40 years, there were only 7 chemo agents that were approved, which was all we had to use in the standard therapy of ovarian cancer. All the 7 agents approved were for treatment indications. And outside of clinical trials, there were no other choices for women being treated for ovary cancer. Maintenance indication was even worse. We did many big trials. I just put 2 examples over there. Sorry. I just put 2 examples over there of 2 of the largest trials, but all of them basically did not show benefit. And in a short period of 4 years, see what happened. Treatment indication, we had 3 agents approved. And for maintenance indications, we had 4 agents approved. So a lot began to happen and happening very quickly. So the key questions are, what is the target population for which agent should be used for treatment, and of course, how about maintenance? So I was told to briefly touch on the epidemiology of ovarian cancer. This is actually a worldwide map from the WHO, and that's ovary cancer right down there, affects approximately 300,000 women worldwide, and every year kills close to 200,000. And North America actually accounts for about 10% of that, we're the color right there, and half occur in Asian countries. This is incidence of the top 10 cancers that affect women. And what I want to point your attention to is ovary cancer is actually not listed in the first 10. So in incidence, it's not there. But if you look at the map below, look. So ovary cancer is the number 5 killer, even though in incidence is much lower than the other cancers that were listed at the top. So approximately 90% of these ovary cancers are from the surface of the ovary or the fallopian tube or the primary peritoneum, so we call them epithelial cancers, typically asymptomatic in the early stages, which is why most people are diagnosed late. And we believe that 15 to 20% are accounted for by genetic mutations, the most common of which is BRCA1 and 2 mutations, and of course Lynch syndrome, the mismatch repair system. Ovarian cancer treatment is surgery, either as a primary debulking surgery or as neoadjuvant chemotherapy approach with interval cytoreductive surgery. And except for the low-grade stages 1A and B patients, everybody is treated with chemotherapy at the initial part of treatment. The initial chemotherapy is typically carboplatin and Taxol with or without bevacizumab, and maintenance therapy is a new indication that became available in the last maybe 2 years. And this is the surgery that is done for ovarian cancer. It's just there for listing. I'm not going to take you through those. And surgery does have impact. This is a slide from Professor Bristow. And if you look here, this is the median survivor. And if you look at the extent of surgery done, i.e. how clean you leave the belly of the woman after you finish the surgery, it directly correlates to a positive survival impact. So, in the era of targeted therapy, the first agent that was assessed was actually bevacizumab, and the first trial over there is GOG 218 by Robert Berger, and the second one is Timothy Perrin's paper from Europe, which is ICON 7. And the reason why these studies were done is exactly this. If you look here, this is the cancer surface, and you can see that it has a lot of receptors that are directed to react to new vessel promoting molecules. And the most relevant one here is VEGF receptor 1 and 2, which is activated by VEGF as the ligand. And those, of course, are the targets for bevacizumab. And so GOG 218 recruited patients into a 3-arm prospective randomized trial, and those arms are as listed over there. This arm is the Bev throughout, and that is just Bev during treatment. And this was the Kaplan-Meier curve for progression-free survival. As you can see, bevacizumab did lead to a PFS gain of approximately 4 months. And if you look at both trials, they were similar, except the difference is a little smaller in the ICON 7 trial. I should mention, for those who are familiar with this, that they use 7.5 milligrams per kilogram body weight of bevacizumab in the ICON 7 trial. We used 15 milligrams per kilogram body weight in our trial. So in 2018, the FDA approved bevacizumab as part of the frontline maintenance therapy for ovarian cancer. In the 218 trial, it was given for 17 months. So you avoided it in the first adjuvant therapy, and then you give it for the next 5 cycles, which is because we typically give 6 cycles, and then for 12 months after that. Then PARP inhibitors, which I will just briefly go through the basic, but yes. Basically, there's cancer cells and even normal cells sustain double-stranded DNA break that you can see there. And when this happens, there are 2 pathways to repair it. The homologous recombination pathway, which is the high-fidelity, error-proof pathway that leads to normal rejoining. And then this is called non-head joining pathway that typically utilizes the PARP enzyme. In a much simpler version, this is again DNA break occurring. It traps the PARP enzyme because that's one of the enzymes that would be responsible for repairing it. If you block PARP, see what happens. A normal cell, we use the double-stranded homologous recombination repair to repair the damage, and then everything would go back to normal. And here, the repair is error-prone, and in cancer cell, if this is occurring, it will lead to accumulation of damages and cell death. Same thing over here. Actually, I like this diagram better because it's much, much easier. So again, double-stranded break here, and the way it gets repaired is either using the PARP enzyme, which goes to normal. If the PARP enzyme is blocked, again, in normal cell, we use the BRCA genes, or the homologous recombination repair genes, which include the BRCA genes, to repair this if it's intact. If that gene is deficient, then this DNA would not be repaired, and then there will be what we call synthetic lethality, which leads to cell death. Now, I said 15 to 20% of ovary cancers occur as a result of genetic mutation, but if you actually assess the tumor themselves, either somatic or genetic mutation is found in almost 50% of ovary cancers, and these are all related to the homologous recombination repair complex, which is all these genes that make up to 50% of all ovarian cancers. So this emphasizes the relevance of the PARP inhibitors in this this group of cancer. So the PARP inhibitors were investigated simultaneously by different companies in different countries, and over a period of about 4 years, these 4 maintenance trials were published somewhere between 2010 and 2014. The 2 bottom ones relate to olaparib. This one is Rubraca, and the first one there is Zejula. And because of this, look what happened. Olaparib now is approved after third line for germline BRCA for treatment as effective 2014, and after second line is also approved for maintenance therapy, and from June of 2019 is now approved in first line BRCA patients after their initial treatment of ovarian cancer. Rubraca has 2 indications: all-comer maintenance therapy after second line treatment, after second line platinum-sensitive ovarian cancer treatment, and also for treatment indication, also after second line. And niraparib has an approval for maintenance therapy in all comers after they've gone through 2 lines of chemotherapy for platinum-sensitive recurrent ovary cancer. So the trials in detail, I'm not going to spend much time on each of these. However, this is the NOVA trial that led to the approval of niraparib. As you can see, the randomization was 2-to-1, placebo-controlled, and they got niraparib 300 milligrams PO per day or placebo, and the endpoint was progression-free survival. And look at the curve. What is peculiar about this is before this trial, we'd never seen this type of curve in solid tumor. It blew the record. And progression-free survival was 19 months, 21 months in the active treatment group compared to 5.5 months in the placebo group. And when you actually look at the group that did not have BRCA mutation, the PFS was still different, 9 versus 4 months. Then the SOLO2 trial, this is for niraparib. Again, maintenance therapy these patients were required to have BRCA mutation, and they were randomized again 2-to-1 for olaparib versus placebo, and primary endpoint was progression-free survival. Look at the curve, another very wide separation, and with a progression-free survival of 19 months in the active group versus 5 months in the control group. And now the company also did another trial, which is called Study 19 by Jonathan Lederman, and they randomized in a double-blind fashion people to 400 milligrams twice daily of olaparib. And this time, they allowed people that did not have BRCA mutation. That's the big deal about Study 19 compared to Solo 2. And we'll move on from this. This is the Kaplan-Meier curve. Again, you see olaparib there and placebo group there, and this is an all-comer curve. So it was very active. Then rucaparib in area 3, it was a biomarker-based study randomizing people to rucaparib 600 milligrams twice a day versus placebo. These patients had tissue testing for germline and somatic mutation. They also did LOH score, loss of heterozygosity score, and they were categorized into 3 groups, the T-BRCA tissue mutation group, the LOH-high group, and the LOH-low group. And if you look at the T-BRCA and LOH-high group are classified as the HRD, and if you look at the curves, the first one is for BRCA mutation only group. The HRD group includes everybody with either BRCA mutation or HRD or LOH high. And then this is intention to treat analysis, everybody. Again, look at the curve. They separate for each group. And when you look at blinded independent central review, it even looks better. So these are extremely active agents. And what I want you to look at here is just concentrate on these hazard ratios. And I'm sorry I didn't point them out in the other trials, but they're all in the same range, 0.27, 0.20, 0.31. That's where all of them are. But like all treatments, there is toxicity, and the most common ones are listed here. So all grades are the first row in each group. So for hemoglobin, all grades, but this is really the important one, grade 3 and 4 toxicity. And for platelets, all grades, and grade 3 and 4. And for neutropenia, all grades and grade 3 and 4. They're manageable. I should say that for niraparib, if you use a reduced dose of this agent, you get a better profile of platelet than this. 300 milligrams was used in NOVA, but 200 milligrams does the job as well with less platelet toxicity. And treatment interruption, again, it actually looks very concerning if you look at all of them, but here's what you should look at. So in over 80% of the cases across board, the patients did not need to discontinue treatment. They just needed treatment adjustment. For treatment, so all the discussion we've had so far about those trials are for maintenance indications. So for treatment, area 2 was the study for Rubraca. As mentioned before, the dose is 600 milligrams twice a day. These patients had recurrent serous or endometrioid ovarian cancer, had completed at least 1 platinum-based chemotherapy, so it was studied in the second line. They were classified into 3 groups. Again, as I mentioned earlier, and that's the treatment allocation, and look at the curve. This is the BRCA mutation group, which performed the best, and next is the wild type but LOH, so this is the HRD group, again in the middle, and of course the non-BRCA mutation HRD negative group were the lowest performing. For olaparib, quickly, it was a monotherapy that was studied in, this is Solo 3, studied against best choice of chemotherapy, and these are the trial arms. The chemotherapies include liposomal doxorubicin, paclitaxel, gemcitabine, and topotecan. And of course, on the other side of the trial, you got randomized 2 to 1, so 2 to olaparib and 1 to chemo. And look at the overall response rate. That's olaparib arm in green and blue. And if you look, this is actually split per how many lines of chemotherapy the patient received. And as you can imagine, those who have received more than 3 lines tend to have less overall response. But nonetheless, look at the response rate. The people in blue here had complete response. Again, that may not sound as impressive as it is looking on the map, but we simply don't see this type of response after people have been treated with 3 lines of chemo in ovary cancer. And the Kaplan-Meier curves bear witness to what was being reported. On the left side is the blinded independent central review showing olaparib being much better, and this is the investigator-assessed response and progression-free survival. If you look here, so not only was the primary objective met, they looked at all the secondary objective, median time to first treatment, median progression-free survival 2, the effect of the benefit of olaparib continued, to persist. The toxicity data, it's again just concentrate on the enhanced colored areas. Those are the grade 3 and 4 toxicities. The worst of them is anemia, and it was 21%. There was 9.6% for neutropenia, but manageable. For first-line treatment, I showed you that slide at the beginning, looking at the studies done by the GOG. Actually, when I counted last time in the literature, there were probably about 29 maintenance studies done before 2018 for chemotherapy, which included actually a monoclonal antibody against CA125, the Recombination. We studied that, led by Jonathan Berek. Everything was negative. So maintenance simply was not indicated in ovary cancer. We just observed them after they completed initial therapy. Then olaparib was studied in Solo 1, which in a fashion that we call switch maintenance. So you complete chemotherapy. In this case, they were required to have germline mutation, although a couple of the patients had tissue mutation in the HR system. And then you received olaparib, as shown here, 300 milligrams twice a day to 60 patients, or placebo, 131 patients, because it was a 2-to-1 randomization. And these were the endpoints. Primary endpoint was investigator-assessed PFS, and the secondary endpoints are listed over there look what happened. So, again, the olaparib group, in fact, the median progression-free survival has not been met. And for the placebo group, I think it was 13.8 months. Okay, I was looking for that. At approximately 3 years, only 60% of the olaparib group remained progression-free, and 27% of the placebo group remained progression-free. Just like we showed for niraparib, look at the secondary endpoints: median time to first subsequent therapy, median progression-free survival 2, and median time to second subsequent therapy. Look how persistent the benefit remained. So these are beyond incredible. Look at the hazard ratio, 0.3, just like I mentioned. Toxicity, of course, we have to talk about. The most common is nausea, and fatigue and asthenia is the second most common. And the grade 3, 4 components of the toxicity is what you see in those enhanced areas. Again, manageable with very minimal discontinuation rate. And this led to the approval of olaparib as switch maintenance following first-line treatment for ovarian cancer in patients who have germline mutation in ovarian cancer, but people with tissue mutation are being given the drug as well, the somatic mutation. So, I've got time. I wanted to just limit the talk to the agents that have been approved and the study that led to the approval, because that's what is relevant to the pathway development community that are meeting here today. But just for you to know, European Society for Medical Oncology meeting took place last month, and 3 very big trials were presented. One is called PRIMA. The PRIMA was a trial of niraparib in all-comer ovarian cancer patients who had residual tumor. After they completed first-line chemotherapy, they were randomized to receive either niraparib 300 milligrams once a day, or placebo. And this treatment was for about 2 to 3 years, depending on which arm of the trial you went into. And all the patients were required to have residual disease to be on the trial, and it was a positive trial. Hazard ratio, same place we've seen it for olaparib, is about 0.3, 0.34, 0.4. The other trial that was presented was PIOLA-1, which combined olaparib with bevacizumab as maintenance in patients that have been treated for first-line ovarian cancer. Again, it's bevacizumab with olaparib, and then the other arm. I think there was an observation arm, but it did not have an olaparib-only arm. It was a positive trial. That one too showed that combination is very active in prolonging PFS in ovarian cancer. And then the third big trial is called the VELIA trial. It's an agent that is called veliparib, which is not currently approved, at least in the GYN cancer space. This agent was combined with chemotherapy throughout, and then in the one arm, it was continued as maintenance. The other arm was no veliparib and no veliparib maintenance. I believe there was a third arm that was veliparib during chemo, but no maintenance. It was positive as well, and we're expecting that most likely this 3 trials will lead to new filings with the FDA, and we'll see how that goes. And when we get there, we'll hopefully be discussing it, maybe next year. But some key questions remain, and these are the questions. I've just told you SOLO-1 is positive. Are we going to move olaparib to first-line treatment for BRCA-mutated ovarian cancer patients? That has been done, effective 4 months ago. What happens at the time of recurrence? Because we have no data yet that suggests that PARP will work if we give it after PARP. So now that we've used it in the first line, if these patients with BRCA mutation, if they recall, what are we going to do? Is PARP still an option? Some trials are going on to look at that. The second question is, PRIMA is positive. Are we going to move niraparib to first line for all high-grade ovarian cancer patients, which is the way the trial was done? I can assure you that that is certainly the intention of the company. I'm sure they're at the door of the FDA as we speak. PAOLA-1 is positive. Are we going to now use bevacizumab with olaparib as maintenance in first-line ovarian cancer trial? Is the cost of that strategy going to be a problem? And is that strategy better than SOLO-1? Those are going to be the questions that we need to discuss if and when this becomes approved by the FDA. And as I just said, VELIA trial is positive as well. So are we about to see a fourth PARP inhibitor in the ovarian cancer space? So these are questions that have not been answered. So I actually would, since I have saved quite a bit of time, I'll just quickly talk about our pathway process. And so we have one of the earliest pathways in the country at the University of Pittsburgh Medical Center. We're no longer the custodian of that pathway system. It's been acquired by a surveyor. And the way the pathway functions is it actually selects expert. There's an expert committee for each cancer site, whether it's liquid or solid malignancy, and it draws experts from all over the country, from the east, from the central part of the country, from the west coast. And these committees meet roughly about 4 times a year. Ad hoc meetings or can be conducted when and if necessary. And similar to what the gentleman from Dana-Farber had mentioned, we strictly debate based on evidence and all publish data, especially phase 3 data or critical phase 2 or even phase 1B, make their way into the committee deliberations. We debate what needs to be in each treatment space or maintenance space. And after the debate, committee members are actually not asked to vote at the time of the deliberations. The voting is made individualistic. A discrete email will go to each voting member about within 72 hours after the debate is over, and they would vote for which of the options that were debated that they want to pick. What the pathway tries to do is probably why we're having this discussion today, because now, as I mentioned, we have 4 agents approved for maintenance. We have 2, probably soon to be 3, approved for treatment, all new agents. So it can be confusing for folks who treat ovarian cancer, and the pathway for this purpose is meant to help them, that if you put the patient scenario, the pathway comes up with the best recommendation. And so that process, it's laborious, but it's a worthwhile process because it prioritizes efficacy as the number one, priority. And the second priority is, of course, toxicity, as we should, and cost is put at the bottom. And that algorithm helps us to choose the most efficacious and the least expensive treatment. And yet, be able to minimize toxicity in prescribing treatment to patients. I think I should now take questions.
Thank you for a great presentation. My question relates to the role of where Avastin fits in. From a value-based perspective, both PARP inhibitors and Avastin are extremely expensive. Now we have updated data from GOG 0218 saying that there is no overall survival benefit for Avastin. So in your opinion, going forward, should Avastin be on a pathway or for ovarian cancer at all?
Thank you for that question and for your comment. Yes, that's a very important question that should be addressed. Avastin is an interesting medication because although it was the first to be looked at for maintenance, the benefit in PFS, it's, to put it at best, modest. Which is what you were alluding to with the GOG 0281 study. However, there is a subset of patients, okay, who are symptomatic with troublesome ascites, patients, for instance, who may have, who are GBRCA negative, HRD negative. There are many, many folks who think that Avastin does have a role in those population of patients. Wide application of Avastin is probably not going to happen based on the other agents that we have. I can tell you that if you look across the country, only about 30% of medical OGYN oncologists treating ovarian cancer, only 30% are using Avastin as maintenance in the first line.
Thank you, sir.
Thank you very much. I'm sorry, we have one more question. We have time for one more.
Well, thank you. So just by way of introduction, I'm Aubrey Kelly. I work at Amgen, and I'm also a pediatric cancer mom. My son is an AML survivor. He's 4 years old. The question I have is that this is beautiful data. This is very, very, very exciting data. And when I view it as the mom of a pediatric cancer survivor, I say, wow, this is practice-changing data. How quickly are we from the point of information being available to being able to help treat patients? And the slide yesterday just keeps resonating in my mind that it takes 17 years to change 14%. And so my question is, above and beyond updating and the decision around clinical pathways, what is your institution doing to help bring that education, talk about that physician-patient relationship, et cetera?
We're trying to do a lot. I mean, that's the whole idea behind the pathway creation. We want to make sure, or we wanted to make sure, that everybody is allowed to have an opportunity to be exposed to the best standard therapy that is available there based on evidence. And I can give you an example. I think I was the first to give olaparib to a patient in 2014. I treated a patient with olaparib, I believe, a few days after it was approved. So we actually would call for an emergency meeting in my institution, those who are involved with the pathway, if we think something critical, like when the FDA made a declaration about olaratumab. I don't know if you're familiar with that. We felt it was important to go straight into a deliberation and decide what we're going to do with olaratumab, which was remove it. And so, yeah, we're trying our best to make sure, and we encourage people to join the pathway or form their own pathway. Thank you.
Thank you.
Thank you, Dr. Alloway.
Thank you.